And we go for our speaker, Dr. Ayman, elsir. I will give a lecture about the increase in the serum 5100 beta subunit after carotid artery stenting and carotid endarterectomy.
Thank you very much, Mr. Chairman, and Professor Dr. Ayman for the introduction. I'm a Palestinian surgeon. I have the honor to be among you and among my professors and colleagues whom I owe a lot of love and respect. And I'm thankful to the organizing committee of the conference, especially Dr. Nasser, Dr. Imad, Dr. Tariq, for their hospitality. Our study is a collaborative work between Al-Qasr Al-Aini, led by Professor Dr. Hussein Khairi, whom I thank very much, and Professor Christos Eliapis in Attikon University Hospital in Greece. And the title of our study is Increase in Serum S100B Protein After Carotid Artery Stenting and Carotid Endarterectomy. I have no conflict of interest. Let's have this small brief about the histology. We have in the brain the neurocytes, and we have also the glial cells, this cell in blue, these connective tissues inside the brain that secretes some biomarkers. One of them is the S100 beta protein. And the idea why I choose this biomarker is that the blood-brain barrier, if it has breached these markers, and especially the S100B protein, will be released in the cerebral spinal fluid and the circulation. The astrocytes specifically secretes this protein if the blood-brain barrier is breached. And actually, the literature studied this protein and its role in traumatic brain injury, especially in pediatric age, when the history taken is a little bit difficult in this group of patients. It has been studied actually also in some medical conditions like convulsions and neuroinflammatory diseases. However, scanty studies have studied this protein in the relation of carotid revascularization. Our aim of the study is to detect the serum level of S100B protein before, during, and 24 hours after CAS and SIA. We are aiming to see if there is more silent brain injury in one of these or two of them. Let's see what we got. We prospectively collected 30 patients, not randomly, but we had 15 patients of CAS. We have used actually the Abbott EmboShield, a distal protective device, and the Abbott Exact Stent. We have no potential conflict of interest, but we wanted to unify the study. All CAS are done through femoral access. For the 15 groups, 15 patients in the SIA, we used primary closure with the microvascular technique in 80% of cases. They are the male cases, and dacron patch in the rest of the cases, which are the female patients. We use general anesthesia, and we use cerebral oximeter as a neuro monitoring. We monitored the S100 in arterial blood, not in the CSF, because of the invasiveness of this procedure, of the sampling. We collected the S100 before the procedure, during the procedure, which means after stenting in CAS cases, and just before declamping for SIA arm of the study, because we wanted to have the maximum effect of silent brain injury. And of course, 24 hours after the procedure. We had similar demographic data. We have similar atherosclerotic risk groups, mix of symptomatic and asymptomatic cases. However, we couldn't randomly distribute the cases because we have some indications that let us to choose the CAS versus SIA. We have significant differences between the groups. we found elevated S100B protein during the procedure, but not significant difference. But the significant difference was 24 hours later, which means that this protein is released slowly and detected with high measures or levels in the CAS group. So if we look at this box plot, the first 3 boxes are CAS, the next 3 boxes are SIA. And this is before, during, after, before, during, after. We can see the increase of the level of S100B protein significantly among the 2 groups. This is the first study in literature that studies the correlation between the plaque type and the S100B protein. We wanted to see the plaque type, which is measured, which is identified by duplex scan, the plaque type 1 or 2, which is more vulnerable, which has a more equilucent content. And we found that there are shooting levels of S100B protein, especially in CAS cases. However, for type 3 and 4, which are more benign plaques, we have also raised levels in CAS cases more than SIA, but not to shooting levels. And there's a significant difference in between the 2 groups. We also found something nice in the SIA arm of the study, especially by using the cerebral oximeter. We have found, as we can see in this line graph, that the blue line is the ipsilateral, the operating site, the oximeter results, and we have, and the orange one is the contralateral side. If there is hypoxia in the contralateral side, this will lead to increase in the S100B protein profoundly. So if the other side that we are not operating upon has normal saturation of oxygen, this will lead to compensation of the overall cerebral silent injury. But if the other side is extremely stenotic, and this is seen through the cerebral oximeter, the overall silent brain injury is evident. Actually, there's a limitation of our study that the sample size calculation showed that if we want to have a statistically powerful study, we need to increase the sample to, for example, 80 cases per each arm of the study. I didn't say that we have no strokes, no TIA, no death cases in this study, luckily for the patients. CAS is more injurious, we can conclude that, but on the level of silent brain injury, which goes with the debate that we have voted just previously a few minutes ago. Plaque type 1 or 2 is associated with elevated S100B protein, especially in CAS cases. We can say that the S100B protein is a useful neurological biomarker. We can use it in the future, maybe to predict the neurological morbidities. We can use it, we know that in the coming years we have a huge randomized studies comparing CAS and XIA with the medical treatment, the ACST2 trial and the CRIS2 trial. So the S100B protein may be detected pre-operatively or pre-procedure, and it can see which cases have high risk to management, and the other cases which have no elevated in S100B protein in asymptomatic cases can go to medical treatment, for example. We have seen that the contralateral carotid can compensate for the ischemia caused by ipsilateral clamping. Our study is a pilot study that can be continued on a larger scale of cases on a larger randomized control trial. Thank you very much.